Today we are talking about lymphoma versus thymoma in dogs, differentials for a mediastinal mass. Both can cause respiratory signs, pleural effusion, or cranial vena cava compression, but they arise from different cells and have different treatment goals. Mediastinal lymphoma is usually a high-grade T-cell malignancy involving the thymus, mediastinal lymph nodes, or both. A transformed lymphocyte acquires mutations that allow uncontrolled proliferation, resistance to apoptosis, and invasion of normal tissue. The exact trigger is rarely identified, although genetics, immune dysregulation, aging-related mutations, and environmental exposures may contribute. It can affect younger adult dogs and may produce parathyroid hormone-related protein, causing hypercalcemia, polyuria, polydipsia, weakness, dehydration, and renal injury. A thymoma develops from thymic epithelial cells and usually affects older dogs, often around 9 to 11 years of age. The mass contains many non-neoplastic lymphocytes, so cytology may resemble lymphoma. Thymomas may remain encapsulated or invade the great vessels, pericardium, lungs, and surrounding tissue. They can also trigger acquired myasthenia gravis, in which antibodies destroy nicotinic acetylcholine receptors at the neuromuscular junction. Watch for exercise-induced weakness, dysphagia, regurgitation, megaesophagus, and aspiration pneumonia. Thoracic radiographs identify the mass and pleural fluid, while contrast-enhanced CT assesses invasion and surgical resectability. Cytology, flow cytometry, and sometimes histopathology help distinguish lymphoma from thymic epithelial disease. Blood work should evaluate calcium, renal values, and blood cell counts, and dogs with weakness or regurgitation should be tested for myasthenia gravis. Mediastinal lymphoma is treated as systemic disease, commonly with CHOP chemotherapy. Cyclophosphamide cross-links DNA, doxorubicin intercalates into DNA and inhibits topoisomerase II, vincristine blocks microtubule formation, and prednisone activates glucocorticoid receptors to promote lymphocyte apoptosis. Without chemotherapy, aggressive lymphoma may progress within 4 to 6 weeks. General T-cell lymphoma survival with multi-drug chemotherapy is often around 6 to 8 months, but mediastinal disease may be more aggressive. One retrospective study reported a median overall survival of about 194 days with CHOP. Complete remission improves survival, while pleural effusion, systemic illness, relapse, and severe hypercalcemia worsen it. CHOP requires close monitoring because bone marrow and gastrointestinal cells can also be injured. A complete blood count is checked before treatment, and fever, severe lethargy, bruising, vomiting, diarrhea, or refusal to eat may indicate toxicity. Cyclophosphamide can cause sterile hemorrhagic cystitis, so monitor for frequent urination, straining, or blood in the urine. Vincristine may cause constipation, ileus, weakness, or neuropathy and causes severe tissue injury if it leaks outside the vein. Doxorubicin can cause infusion reactions and cumulative cardiomyopathy, making cardiac assessment important in dogs with heart disease. Prednisone commonly causes panting, increased thirst, urination and appetite, muscle loss, and infection risk. It should ideally not be started before diagnostic sampling because it can reduce diagnostic yield and promote drug resistance. For a resectable thymoma, complete surgical excision offers the best chance for long-term control. Surgical studies report median survival of roughly 2 to more than 3 years. Invasive disease, incomplete excision, metastasis, thymic carcinoma, myasthenia gravis, megaesophagus, and aspiration pneumonia worsen prognosis. Radiation may control an unresectable or incompletely excised tumor, while chemotherapy has a less predictable role. Dogs receiving pyridostigmine for myasthenia gravis must be monitored for drooling, diarrhea, abdominal cramping, excessive secretions, muscle fasciculations, worsening weakness, abnormal heart rate, or breathing difficulty. Excessive dosing can produce a cholinergic crisis that resembles worsening myasthenia. After thymectomy, watch for hemorrhage, pneumothorax, respiratory compromise, persistent regurgitation, and aspiration pneumonia. Myasthenia may take time to improve and can sometimes persist after tumor removal. There is no proven way to prevent lymphoma or thymoma. Risk reduction centers on limiting unnecessary carcinogen exposure, maintaining regular examinations, and investigating respiratory signs, regurgitation, hypercalcemia, or exercise intolerance early. The key distinction is that mediastinal lymphoma is usually a systemic, aggressive lymphoid cancer managed with chemotherapy, while thymoma is an epithelial tumor in which successful local control can sometimes provide years of good quality life. If you have topics you would like to suggest, reach out to @dogdersgame or dogtoursgame@gmail.com.